This year's annual EBMT meeting will begin with a keynote lecture from Dr. María-Victoria Mateos, whose work in the field of multiple myeloma has been a key point of reference for haematologists around the world. Dr. Mateos, many thanks for joining us.
Thank you very much.
To begin with, perhaps you could start by telling us what got you started in the field of multiple myeloma and what led you to focus your work in this area.
When I finished my specialty in hematology at the University of Salamanca and at the University Hospital of Salamanca, I had the opportunity to meet with Professor San Miguel. He has been my mentor, and he was really the person who introduced me to the multiple myeloma field. And now I had the opportunity to be one of the chair of the Spanish myeloma group, involved in the clinical trials design, as well as the coordination of many clinical trials.
So what got you interested in multiple myeloma?
Multiple myeloma is a rare disease for which melphalan and prednisone has been actually the conventional therapy for more than 40 years. When I started to be focused much more in multiple myeloma, novel agents introduced into the clinical research for patients with multiple myeloma. We had the opportunity to see how the treatment landscape for myeloma patients rapidly evolved, and definitely I had also the opportunity to see how the outcome and especially the overall survival for patients with multiple myeloma significantly improved, and now it is possible to have in front of us patients with multiple myeloma living more than 10, 15 or even 20 years.
Your lecture looks at how treatment is evolving for newly diagnosed transplant-eligible multiple myeloma patients. What is the status of treatment today and what more do we need to learn?
The treatment of patients with multiple myeloma has rapidly evolved, and many new agents have been incorporated as part of the induction, consolidation, maintenance therapy in the newly diagnosed myeloma patients, and at the relapse setting, many new approaches are emerging. However, it's important to remark how, in spite of the fact that new drugs have been incorporated as part of the induction, as well as even the monoclonal antibodies, autologous stem cell transplantation is a complementary strategy, and high-dose melphalan followed by autologous stem cell transplantation is able to upgrade the quality of the response. And in the phase 3 clinical trials we have right now, transplant continues being superior to no transplant in terms of progression-free survival, although we are incorporating new tools like minimal residual disease assessment as well as risk assessment of the patients. And when we incorporate these two things, I think that in the future maybe we can individualize more and more the treatment of our newly diagnosed myeloma patient, and we can select a small subgroup of patients that can potentially avoid autologous stem cell transplantation in the upfront setting.
What's next for multiple myeloma then? Where do you see us being in 5-10 years?
We will have the opportunity to see how cell therapy will be incorporated, and maybe for patients with high-risk features after autologous stem cell transplantation, or maybe replacing autologous stem cell transplantation, who knows, we can incorporate the cell therapy, bispecific monoclonal antibodies, or maybe CAR T cells. And definitely in 5 or 10 years, I think that we will be able to offer a potential cure to some group of patients with newly diagnosed myeloma patients, especially maybe patients at standard risk, I repeat, and again achieving minimal residual disease negative.
Dr. Mateos, many thanks for joining us.
Thank you very much for the invitation to the keynote lecture.